So we only have an hour, so let's get Dr. Hurvitz on the screen, and she will be doing her presentation. Welcome.
Thank you so much. It's my pleasure to be here. It's such an important organization, and I'm so pleased to be able to speak with you all and hopefully address some of your questions. I know many of you are very familiar with the information I'll be going through today, and for some of you, it'll be newer information. I hope that there is something for everyone here. So I'm going to get started on my talk now. Here is what I'll be talking about. I will be specifically focusing on updates in the treatment of HER2-positive metastatic breast cancer. So we know breast cancer is not one disease. There are multiple disease types. And now we break it down based on which receptors are expressed, hormone receptors, ER and PR, and HER2, another receptor, which is overexpressed in about 15% or 20% of breast cancers, is another subtype. And about half to 60% of HER2-positive breast cancer is characterized by co-expression of hormone receptors. Sometimes we call these tumors triple positive. It's a little bit of a misnomer because sometimes the estrogen receptor is positive and the progesterone receptor is negative in HER2-positive breast cancer, but it's still what I call co-expressing, hormone receptor co-expressing HER2-positive breast cancer. So I'll highlight some of the new data relating to the management of HER2-positive breast cancer, including those tumors that co-express the hormone receptors. So what I want to start with first is to reflect on the changes that have occurred as a result of the discovery that HER2 can be amplified in about 15 to 20% of breast cancers. This was originally discovered in 1987 by my mentor, Dr. Slayman. He showed that this amplification of the gene leads to too many copies of the receptors, shown in red in this picture. When there are too many copies of the receptors or too much of that receptor protein expressed on the tumor cell, that leads to more aggressive tumor behavior, a higher chance that the lymph nodes will be involved at the original diagnosis or a more advanced stage, and a lower chance of long-term survival. All of that would have been bad news and a sad ending to the story had scientists not gone on to develop the first targeted therapy that targets HER2 called trastuzumab, also known as Herceptin. Trastuzumab is an antibody shown in yellow there that binds to the outside of the HER2 receptor and in some way, we're still debating how it works, stops that receptor from turning on intracellular or signaling pathways or proteins within the cell that make the cell divide and grow, and may also stimulate an immune response against the tumor cells when the tumor cell is coated with this antibody. And we now know that trastuzumab and other HER2-directed therapies have literally changed the natural history of this disease, turning it from disease that has a very poor prognosis to one that has a much better prognosis. So what evidence do I have on which to base that statement? Well, very recently, the ESME registry data were published. ESME is a registry cohort of comprehensive cancer centers, 18 comprehensive cancer centers, all in France. And what they decided to do was collect data on every woman diagnosed with metastatic breast cancer from 2008 through 2017. And they looked at patients' median overall survival for each year. So they looked, if you look at the box in the right upper corner there, they looked at what is the median overall survival for a patient who was diagnosed with HER2-positive metastatic breast cancer in the year 2008. And you can see it was 39.1 months, meaning half of the patients were alive at 39 months, half had passed away at 39 months if they were diagnosed in 2008. And what's really interesting is that number continues to rise as you go year by year, such that by the year 2013, a woman diagnosed that year with metastatic HER2-positive breast cancer had a 58-month, almost 5-year median overall survival, meaning half the women were alive at 58 months and half had passed away. So we're improving that long-term outcome. What's interesting is that triple negative breast cancer has not seen an improvement in those years. They also looked at those patients. And in that time period, those patients with hormone receptor positive HER2 negative breast cancer had also not seen an improvement in their overall survival. Also, what's interesting is if you look at the years 2014, 15, and 16, they hadn't yet reached the median overall survival for patients diagnosed in those years, meaning more than half of the patients were still alive at the time of this data capture. So indeed, it's a very good news story, and we have data suggesting that patients with HER2-positive breast cancer in an era where we can target it with medicines have the best overall survival expectation. And now we have an expanding armamentarium of all these drugs shown here available for patients with HER2-positive breast cancer in the metastatic setting. So it's incumbent upon us as scientists and you as patients to have rich discussions about which agent should be used in which setting. We have three monoclonal antibodies that target the outside of the HER2 receptor, trastuzumab, margituximab, and pertuzumab. We have three orally available, meaning pill form, tyrosine kinase inhibitors that get on the inside of the cancer cell, neratinib, lapatinib, and toucatinib. And we have 2 antibody drug conjugates, TDM1 and TDXT, which have the chemotherapy loaded on the antibody to deliver the chemo specifically to the cancer cell. There are also some studies that have recently come out about pyrotinib, another tyrosine kinase inhibitor, and SID985, or trastuzumab duocarmazine. Those agents have shown positive results, but are not yet available in the US because their efficacy may not be counterbalanced well by the toxicity. Both of them have toxicities that are a bit concerning. So let's talk about standard first-line therapy. This may change very quickly. If I'm invited back next year to talk to you or the year after, I may have a very different recommendation for first line. And what I mean by first line is the first therapy offered to a patient when they have for metastatic disease, stage 4 breast cancer. And so the standard first-line therapy involves the use of a drug, pertuzumab, the monoclonal antibody shown in blue here, that blocks HER2 at a different part of HER2 than trastuzumab. It blocks HER2 at the site where HER2 and HER3 dimerize or come together. HER2 is a receptor that doesn't get activated by binding to a protein called a ligand. Instead, it gets activated by dimerizing, or I like to say mating, with another receptor. And the preferred partner for HER2 is HER3. Pertuzumab blocks that dimerization and also, and in doing so, blocks the pathways shown here, the PI3 kinase AKT mTOR pathway, which is a very potent pathway that turns on cell division and tumor growth. The drug doesn't work really well as a single agent, but preclinical or laboratory-based work indicated that it works very well when given with trastuzumab. And so clinical trials were done where the 2 antibodies were given together in combination with chemotherapy. And this clinical trial, the phase 3 clinical trial that tested this combination, was called Cleopatra. It was published, first presented in 2012, and led to the FDA approval of pertuzumab for metastatic breast cancer in patients who had never received prior therapy for this disease. Patients received trastuzumab plus pertuzumab plus docetaxel, a chemotherapy, or trastuzumab plus docetaxel without the pertuzumab. The patients who received the pertuzumab regimen, the THP regimen, had a significantly better length of time of their disease being controlled, progression-free survival, as well as a significantly longer overall survival. They lived on average a year longer, more than a year longer, than patients who did not receive pertuzumab. The median overall survival was 57 months, almost 5 years at the most recent reporting. And so no regimen or therapy has yet gone head-to-head to replace THP as the standard first-line therapy, but soon there will be data because there are therapies, including one I'll be talking about in a moment, TDXT, which is challenging this first-place stance. And so what I'm showing you here is how the progression-free survival has evolved over time. In the past, in 2001, before trastuzumab was widely available in the metastatic setting, patients who received chemotherapy alone would have their disease progress in less than 6 months and increased over time. And at the 2012 reporting of Cleopatra, you can see you got all the way up to 18 and a half months. So I'm excited and hopeful that we might see patients the average patient go much longer than that in future trials. It's not to see that everybody has their disease get worse at 18 months, just that about half of patients do. I have patients who are still on the HP maintenance, the trastuzumab, pertuzumab maintenance, without having progression for over 5 years. So long-term progression-free survival is possible. What about standard second-line therapy? Well, the standard second-line agent until recent was TDM1 or trastuzumab emtansine. On the left, you can see a picture of it. It is essentially the trastuzumab antibody that is linked stably to a very, very potent chemotherapy called a derivative of maytansine, DM. The maytansine is about 100 times more potent than paclitaxel chemotherapy. It couldn't be given as a single agent. It was evaluated in the 1980s. It was way too toxic, but scientists figured out how to stably link it to the antibody such that the antibody would deliver the chemo to the cancer cell that has too much HER2 on it. Kind of a Trojan horse effect or a smart bomb. The study that led to its approval in 2013 was Amelia. TDM1 led to lapatinib with chemotherapy, capecitabine, and TDM1 was shown to improve the progression-free survival and overall survival. And so for almost 10 years, TDM1 has been in the second place position for patients who've received one prior line of therapy, including trastuzumab and a taxane for metastatic disease. However, very recently, this molecule came along, trastuzumab deruxtecan. This is also an antibody drug conjugate, but it's a little bit different. This antibody drug conjugate, instead of having 3 to 4 of the chemo molecules tagged onto the antibody per antibody, there's 7 to 8, so there's a lot more chemo per antibody. The chemotherapy, once it's released inside of the HER2-positive cancer cell, is called membrane permeable. It can leave that cancer cell and go out and kill nearby cancer cells that may not have high levels of HER2 expression. It is a very potent chemo, and the chemo payload is different from the one. It works differently from the one in TDM1. This drug was tested in a clinical trial called Destiny Breast 01. Oh, and shown here is just a little picture of some preclinical work. I think it's actually interesting. So on the left panel in the red, you can see scientists have co-cultured HER2-positive breast cancer cells and HER2-negative breast cancer cells shown in the purple. So the whole thing, the whole box on the left is full of cancer. Brown are HER2-positive, blue are HER2-negative. In the middle panel, the cancer cells are treated with TDM1. TDM1 only kills those HER2-positive cancer cells that have high expression of HER2. But when you treat the two tumors with TDXT, all the tumors, both the HER2-positive and HER2-negative tumors, are killed owing to this bystander effect, or the fact that the payload can kill neighboring tumor cells. So the Destiny-Breast03 clinical trial was a study that was the first trial to compare TDXT to another therapy, and they chose to go head-to-head against TDM1. Now, there was another trial I didn't show you called Destiny-Breast01, where TDXT was evaluated in 184 patients. All patients got the therapy. The patients were very heavily pretreated, like fifth or sixth line, and the study showed a very good response rate of 64% of patients having complete response of their tumor or a very solid response of their tumor, and the progression-free survival was over 16 months. Very promising data. So they took this drug and went head-to-head against TDM1. Patients who'd previously had trastuzumab and a taxane and for their metastatic disease that was HER2-positive got randomly assigned to TDXT or TDM1. Some of the patients had brain metastases. Half of the patients had had more than one prior line of therapy, and 3/4 of the patients almost had liver involvement or lung involvement, visceral metastases. And these data were presented last September at ESMO, and this is a Kaplan-Meier curve showing the difference between the two treatment arms. In the dark blue arm, you can see the patients treated with TDXT, they all start out at 100% having their disease controlled, and over time, the patients in the light gray curve treated with TDM1, more and more patients lose control of their disease or have a progression event. So their curve drops off. But the patients in the dark blue curve continue to have disease control. The median progression-free survival for TDM1 was under 7 months. It hadn't even been reached yet for TDXT. And by some estimates, it's over 2 years. So very phenomenal results that benefited patients regardless of the number of prior lines of therapy they've had, whether or not their tumor co-expressed hormone receptors, whether or not they had a history of brain metastases. Very exciting data. And this here is what's called a waterfall plot showing you each little column on the top curve and the bottom curve shows how much a patient's tumors responded. So the 4 on the very far left above the 0 point had their disease grow. The rest of the patients, almost all of them, experienced disease shrinkage with TDXT. And in fact, 80% of patients had either a complete response or a partial response measurable by scan. And if you compare that curve to TDM1, it compares very favorably to TDM1, where a lot of patients had disease growth as their best response. Adverse events are notable with TDXT. You can see patients develop more nausea, neutropenia, meaning a lowering of the white count, hair thinning, and diarrhea. Because this payload can kill nearby tumor cells, it can also kill nearby normal cells, so it has more toxicity than TDM1. TDM1 has more effects on the liver and platelets, however. And then it's important to know that TDXT can cause inflammation of the lungs called interstitial lung disease or pneumonitis. This occurred in this trial in about 10.5% of patients. No patients died of it in this study, and no patients had grade 4 or life-threatening toxicity, but 2 patients had serious ILD. So this is a drug in which patients must be monitored very closely, and if any patient develops shortness of breath or cough while on this therapy, the treatment must be held and permanently stopped if ILD is diagnosed. So what I've done now is shown how this drug compares to other drugs in the second-line setting, including trastuzumab and taxane. And you can see this 25 months is better than any other reported trial. In fact, TDXT looks better in this study, where patients are more heavily pretreated, than the THP regimen looked in the Cleopatra study I showed you in the first-line setting. If you recall, in that study, the median PFS was 18 months. So my prediction, if I'm going to Vegas and placing a bet, is that TDXT will beat THP in the current ongoing Destiny-Breast09 clinical trial, where TDXT is being compared to THP in the first-line setting. But we'll have to wait and see those results. So here is the current National Comprehensive Cancer Network guidelines for first and second line setting. THP is preferred, and TDXT is the second line preferred therapy, moving TDM1 down. TDXT can be the first line setting in a patient whose disease recurs really quickly after treatment for early stage disease. Now, in the latter part of my talk, I'll talk about some newer antibody drug conjugates. The first one I'll focus on is trastuzumab duocarmazine, or SID985. This too is an antibody drug conjugate similar to TDM1 and TDXT, but the payload is a bit different. It works against it's an alkylator, and it works against the DNA itself of tumors. And the drug antibody ratio is low, meaning there are fewer molecules of the drug per antibody than we see with TDXT. It showed very interesting early phase data, and the TULIP trial was a phase 3 clinical trial to evaluate this drug compared to treatment of physician's choice in the control arm. And as presented at ESMO last fall, you can see that SID985 had a median PFS of 7 months, which was just over 2 months better than using standard of care HER2-targeted therapy plus chemo. However, and it did meet its primary endpoint. However, the objective response rates, if you look here, are kind of low. Only about 27-28% of patients had shrinkage of their tumor, which, if you remember from TDXT, it was 80% of patients. So that's a little bit lower than we like to see, because we're greedy in the breast cancer field. Moreover, there were adverse events noted that are concerning to me as a clinician. Eye toxicity. Patients, the majority of patients had issues with their eyes with this treatment. They had difficulty with dry eyes, with keratitis, inflammation of the eyes, needing to be followed by ophthalmologists and use lubricating eye drops, kind of serious events. And they also saw pneumonitis in this study as well in about 8% of patients. It was grade 3 or 4 in 2% of patients. So it's a little bit concerning as well. And there were some fatal cases due to adverse events. So we haven't seen this FDA approved yet. And my suspicion is that the FDA has concerns about the toxicity of this agent as well, and is waiting to see more. I don't know this for sure, but my assumption is they're waiting to see more safety and efficacy data before approving. We also have a tyrosine kinase inhibitor, a novel one called Twocatinim, that was FDA approved now over a year ago. This is a really interesting molecule. Remember, tyrosine kinase inhibitors are pill forms. They're chemicals that get inside of a HER2 overexpressing cancer cell and target the intracellular portion of that receptor. Now, usually chemical pills, we can't be really specific about the target it goes after, which is unlike antibodies, where you can specifically target the receptor you're going after. So the problem with these tyrosine kinase inhibitors that you take as a pill is they hit many receptors, and that can cause toxicity. Because if you hit HER1, which is also known as epidermal growth factor receptor, that can cause a lot of diarrhea. Lapatinib and neratinib both hit HER1 or EGFR and cause a lot of diarrhea and skin toxicity. Toucatinib is a novel or new type of tyrosine kinase inhibitor where the scientists have figured out how to selectively go after HER2, putting the brakes very, very slightly on HER1, so much less toxicity because it's not inhibiting EGFR as much. And so the HER2CLIMB large 2 randomized controlled trial compared Toucatinib in combination with capecitabine, otherwise known as Xeloda, with trastuzumab, versus capecitabine trastuzumab in patients with HER2-positive breast cancer who had already received 2 prior lines of therapy in the metastatic setting. This was a very uniquely designed study because they allowed patients on trial who had active, progressing brain metastases or previously treated brain metastases or brand new brain metastases. Half the patients had brain metastases in this study. And it's such a unique design to allow these patients onto the trial because HER2-positive breast cancer, 30 to 50% of patients with metastatic disease at some point will develop brain mets. And usually trials have excluded these patients. So I applauded the makers of this study for including these patients. And the reason they did include these patients is because they knew that toucatinib could cross the blood-brain barrier and may have activity in the brain. Indeed, when they looked at their results, shown here on the left, patients treated with toucatinib in combination with CAPE and trastuzumab had a significantly prolonged progression-free survival by over 2 months that met their statistical significance. Also, and this was for all patients with or without brain mets, it showed an improved overall survival that was statistically significant, more than a 5-month improvement in overall survival by using toucatinib. And also, if you look at the brain metastases data, it improved outcomes for those patients with brain metastases, including overall survival. So we also have other tyrosine kinase inhibitors such as paxotaxol here. That too causes a lot of diarrhea, so I'm not going to spend time showing you the Chinese study that evaluated that agent and showed it was superior to lapatinib. I don't see that agent being approved in the States. I wouldn't use it personally due to the toxicity. My preference would be toucatinib. What I'm showing on this graph here is the progression-free survival of all of the tyrosine kinase inhibitors we have, lapatinib, neratinib, toucatinib, and pyrotinib, and comparing that to TDXT and the PFS we saw. So it's just underscoring that TDXT, in my opinion, should be used first before we use a TKI based on these cross-trial comparisons. Then let's talk very briefly about Margituximab. This too is FDA approved in the United States based on the SOPHIA clinical trial, which the results of are shown here. So just for a moment, Margituximab is an antibody very, very similar to trastuzumab, but the tail part of the antibody that interfaces or binds to a person's immune cells to turn the immune cells on against cancer is engineered to more tightly bind those immune cells called immune effector cells. This drug was compared in the SOPHIA trial in combination with chemotherapy against trastuzumab plus chemotherapy and was shown to improve the time before patients had progression, but only by about 5 weeks or so. So it wasn't like a home run, but it did meet its primary endpoint, and it was shown to be as tolerable really as trastuzumab, except maybe an increased risk of infusion reactions. There was no improvement in how long patients lived with this drug, however. It is FDA approved. It appears to work best in patients who have immune genotypes that predict for a more weak binding of their immune cells to the Margituximab, to the trastuzumab tail or FC portion of the antibody. There now is a test that can be done on patients. You can do a blood test and see if you're a patient who's predicted to have a weaker immune cell binding. And if you are one of those patients, perhaps this would be an agent you could try. But again, these efficacy data are nowhere near what we saw with TDXT. And I think, in my opinion, I would use Margituximab-based therapy after TDXT, after TDM1, after toucatinib in the later line setting. Okay, and then finally, just a couple words on CNS metastases or brain metastases. I told you about the HER2-Climb trial earlier and the fact that half of the patients in the trial had brain metastases. And some of them had active or new brain mets that had not had radiation or surgery. And you can see on the left side in the blue uh, panel or the blue columns of the percent of patients treated with toucatinib who had their brain tumor shrink or disappear on study. 47% of patients treated with toucatinib had brain metastases shrink or disappear, compared to 20% of patients who didn't receive toucatinib, who only received trastuzumab and capecitabine. And then the overall survival for patients with brain metastases is shown on the right side. And as you can see in the blue curve, patients treated with toucatinib who had brain metastases lived longer than patients who were not treated with toucatinib. Interestingly, scientists have always thought that you need a real small molecule to bypass that blood-brain barrier and get into the brain and treat brain metastases. But we've seen some recent data that is challenging this assumption. And these data come from studies relating to TDXT. And so the Destiny Breast study I showed you earlier, where half the patients were treated with the ADC TDA and half received TDM1. These are bulky antibodies loaded with chemo. And the blood-brain barrier is a very tight network in the capillaries of the brain that prevents bulky things from getting through, which is why we thought these ADCs couldn't cross the blood-brain barrier and treat brain metastases. However, in this clinical trial, 15% of the patients who came on the study had a history of brain metastases. They had to have been treated previously by radiation or surgery, but they had a history of brain mets, and you could still measure the brain metastases in the initial brain scan they had when they entered the study. And what you can see is that 64% of patients treated with TDXT had their brain metastases shrink or disappear while on this study with TDXT, and 34% of patients treated with TDM1 had their brain metastases shrink or disappear. So that blood-brain barrier appears to be leaky, allowing through the ADCs. On the left is a waterfall plot showing you the individual changes in each of the patients who had brain tumors, the percentage of shrinkage of the brain tumors on this study. Very interesting data, and there are clinical trials now with TDXT and with TDM1 looking at patients who have active, untreated brain metastases to see how well these therapies work. So stay tuned for more data relating to that. And so here is a list of the full recommendations for HER2-positive breast cancer. I didn't have time today to go through the specifics of hormone receptor co-expression or all new agents that are ongoing in clinical trials that target HER2. Right now, I think we have 6 clinical trials at UCLA alone for patients who have been treated with multiple different HER2-targeted therapies, looking at new types of HER2-targeted therapies. This is a unique disease where we know what is driving the tumor biology, and so scientists are cleverly figuring out how to go after HER2 and improve outcomes for patients. So in the first-line setting, as of today, THP is the preferred regimen, TDXT is the preferred second-line regimen, Toucatinib with capecitabine, the oral chemo, and trastuzumab is preferred third-line regimen and preferred for those with brain mets, even in the second-line setting. TDXT can be used after that if you use toucatinib in the second-line setting. And then you have all these other therapies, including hormonally targeted therapies, available for this disease. And so with that, I'll close my talk and open it up because I think there's a lot of questions.
Thank you so much, Dr. Hurvitz. I've been following the chat, and people are just blown away, by the number of therapies and the data as well. So it's certainly so impressive that there are so many different options for this very aggressive breast cancer. So I'm going to take as many questions as I can, but the first one I'll start with is, So a couple people have asked, they are taking the sub-Q Herceptin, which I believe is called Hylecta, and some are experiencing burning during the injection time and wondering if they should ask if they can switch back to the infusion.
You absolutely certainly can switch back. Sorry, I've done something. Just bear with me a minute. There we go. Now I can see you. You absolutely can switch back to the intravenous formulation. It's the use of subcutaneous formulations, in my opinion, is really for patient convenience and keeping, especially in the COVID era, keeping patients out of the infusion room in crowded areas. So it's really a patient convenience. There's no difference in efficacy. So if it's not working for you and you find it's uncomfortable, you can always just continue doing the infusions.
Great, that's helpful. And for those people that haven't been offered subcutaneous, they should certainly, and that is something they're interested in, they should talk to their doctor, right?
Exactly. Absolutely. I think some doctors aren't even aware of it. I had a patient who lives, far away from the UCLA main campus, and I referred her to a local oncologist and suggested subcutaneous trastuzumab, pertuzumab as maintenance for metastatic disease. And her community doctor had never even heard of it. And now they've tried it with her, and now they're offering it to all their patients. So I think for community oncologists, sometimes it's really hard to keep up with all of the advances in a disease. And often it's the patient who notifies the doctor, hey, there's this new thing out there. Can we try it? So that's why I think this sort of conference and networking is so important.
Yeah, absolutely. And we've heard the same thing of people who haven't been offered it. So a question about a couple of people are asking this. They are both ER positive and HER2 positive and concerned that they've moved from Kadcyla to Enhertu. I'm using the commercial names. I know you used all the chemical names, and it might be helpful to just run through that for some people. But they're concerned that their hormone positive part of their disease is not being addressed. And should they be taking Faslodex or an AI?
Yeah, so first I'll deal with your first note. Yes, the naming for drugs is mind-boggling. It is really hard for me to keep up with the names, and then you've got biosimilars to add to that. So it's first developed, it usually has a number next to it, like TDXT used to be DS8201. So for the longest time, I just called it DS8201. And then it gets a generic name when they're in clinical trials, trastuzumab deruxtecan, sometimes an acronym, TDXT. And then when it gets FDA approved, there's this naming convention that the FDA goes by with the drug company to make a trade name. For example, Enhertu is TDXT. TDM1 or trastuzumab emtansine is Kadcyla. Faslodex is fulvestrant. The reason I always use the generic names is it's important for oncologists not to be promotional. And so when you're doing certified medical activities and educating others, if you're using trade names, it comes off as you pushing a certain drug. And so we're trained to always use the generic name, but I appreciate it's very confusing, and this isn't CME, so I'll use whatever name you want. In terms of the ER positive or hormone receptor positive, that it is an excellent question whether or not you should be throwing endocrine therapy or animal therapy on with your HER2 targeted therapy. And the answer is a bit tricky, but the rule in general is if you're using a chemotherapy-based treatment with HER2 targeted therapy, you shouldn't add the endocrine therapy on with it, because we have clinical trials looking at TDM1 alone or Kadcyla alone versus Kadcyla plus endocrine therapy, and there's no extra benefit by adding the endocrine therapy on at that time. These are studies that were done in the early stage setting prior to surgery where you can measure the response of the tumor, et cetera. There are some studies from long ago that if you give chemo and anti-hormonal therapy together, that they may be antagonistic and work against one another, because chemo needs the cell to be dividing to be active against the cell, and anti-hormonal therapy pulls the cell out of cell division. This is probably too much information for you, but the rule is TDM1, which does have chemo payload with it, should be used on its own, and HER2 should be used on its own unless you're in a clinical trial. But if you're using something like trastuzumab, Herceptin, and Perjeta, you can add the endocrine therapy there, because then you're just using antibody therapy with the anti-estrogen therapy. In that situation, it makes sense.
That is really helpful. Something that I didn't know. So I'm hoping, remember everyone, this is being recorded. It will be on this platform for 30 days, and then it will be on the LBBC website. So you can go back and get out your dictionary, but that's very helpful to know. And I didn't know that. Okay. Is there any evidence that toucatinib can actually prevent brain mets?
So that is going to be looked at in a very large clinical trial ongoing right now called COMPASS, in which patients with early stage breast cancer that's high risk receive toucatinib, which is also known as Tukysa, in the adjuvant setting after their surgery and radiation and everything. And they're going to follow out whether patients have a lower chance of brain metastases occurring than as metastatic disease than not. And they're also looking at it, the HER2-CLIMB study, there have been publications relating solely to the brain metastases data. And there is a delay in progression in the brain. So meaning, yes, it probably can prevent brain metastases. There is a study right now ongoing called HER2-CLIMB, and this is a study looking at combining the powerhouse of TDXT with toucatinib. So you've got TDXT, which shows just this phenomenal activity in patients with HER2-positive disease, and then you add on to it the pill toucatinib to see if you can protect the brain more. And they're allowing patients with active brain mets on that study or no brain mets. So I think in the coming next few years, we're going to have a lot of data to tell us, should we be using toucatinib on top of other therapies to try and prevent brain mets? Should we be focusing on using it to just treat brain mets, et cetera?
Interesting. Well, we will definitely be following that at Living Beyond Breast Cancer and giving everybody updates. We've heard a lot about women who are being considered HER2 low. So can you explain that and sort of where they, just sort of where they fall in treatment?
Yeah, absolutely. This is, I didn't talk about it in this talk because HER2 low is not considered HER2 positive. So, and it opens Pandora's box. This is a hot topic. Stay tuned for ASCO, June 2022. There's going to be very big into that meeting from the Destiny Breast 04 clinical trial. So in a nutshell, HER2 amplification, meaning too many copies of the gene, is tested by a test called FISH, F-I-S-H, in situ hybridization. It's kind of like, yes, the patient's tumor has too many copies of the gene, or no, they do not. The protein on the surface of the cell is tested by a test called immunohistochemistry, where you can actually look at how many receptors of HER2 there are on the cell surface. Most cells in our body have some HER2 expression. HER2 is probably important in the development of the heart as a fetus. We're not sure why it's important in adulthood. It may have to do with protecting the heart after a heart attack, but it's not really known. But in breast cancers, you can have a little bit of expression of HER2 or a moderate expression of HER2, but not amplification of the gene for HER2. And it's not the driving force of that tumor behaving badly. It's just kind of there. It's a bystander, if you will. And when you test the IHC, the immunohistochemistry, you get a score back that says your HER2 is 0, 1+, 2+, or 3+. If it's 3+, you're considered HER2 positive. You go into the category of treatments I just spoke about for a half hour. If you're 1+ or 2+, that's categorized as HER2 low. And in the past, there have been some clinical trials that have looked at whether using drugs like Herceptin work in HER2 low. And all the studies have shown, nope, Herceptin doesn't work. Nope, Kadcyla doesn't work. You need to have HER2 3+ to make these work. But TDXT, because of that bystander effect, where the chemo can leave the cancer cell and kill nearby HER2 low expressing cells, it did show some evidence that it works when the HER2 is 1+ or 2+. In fact, in a phase 1 clinical trial where patients with HER2 negative but low expression of HER2 were treated with TDXT, about 40% of them had their disease shrink. There about a third of patients with triple breast cancer are considered to be HER2 low. 2/3 of patients with hormone receptor positive, HER2 negative breast cancer have HER2 low disease. So a clinical trial called Destiny Breast 04 was conducted where patients with HER2 low metastatic disease got either TDXT or chemo. And there was a press release over a month ago now that the study met its primary endpoint of significantly improving progression-free survival and also improving overall survival, which is really stunning to see overall survival improved at an early interim analysis. So we haven't seen the data yet. They'll be presented at ASCO and we'll be able to dissect the data, but it is very possible this drug will be available for a very large amount of patients now, since it's so common to have HER2 low expression.
Yeah, that is really exciting. We certainly have interfaced with a lot of women who are in that situation. So can TDXT be used after a progression with TDM1?
Yes, we have good evidence that TDXT works after TDM1 because the study that led to the approval of TDXT, called Destiny Breast 01, was done in patients who had all received prior TDM1. And it showed that 64% of patients had a response. The progression-free survival was quite long. The FDA actually granted TDXT accelerated approval in December of 2019, but based on that clinical trial, which is why it's available. So yes, we have very good evidence it works after TDM1. The opposite is not true. We don't know how well TDM1 works after TDXT. Because in the Destiny Breast 01 study, excuse me, 03 study, we didn't look at, how did patients do with TDM1 after TDXT. So from a scientific standpoint, there's no reason why TDM1 wouldn't work because their chemo payloads are very different. It's just we don't have clinical data to tell us.
Okay, so there's so much to learn.
Exactly.
So I'm just going to read this question. This person has seen some data suggesting that you can do paxotaxol with HP for 6 months as a first line of treatment. When would you increase the length of paxotaxol from the standard of 3 to 4 months?
Yes. So first of all, the THP regimen, it's acceptable to use either docetaxel, which is known as Taxotere, or paclitaxel, which is known as Taxol, as long as you're getting the Taxol every week. The two drugs are equivalent. There's good evidence that it doesn't matter which one you do. So you can talk to your doctor about the differences between them and the frequency you receive them and choose which one. The way the Cleopatra study was done is that patients would receive therapy, typically 6 to 8 cycles of therapy, which is roughly 4 to 6 months. And then they could drop the chemo and just continue the HP. And now you can do Phesgo, subcutaneous HP.
Right. People are writing about that.
Exactly. Yes. And so, I basically will look at a patient's scans after 2 months of the taxane, either Taxol or Taxotere, make sure the disease is responding appropriately. I typically give 6 cycles, which is about 4 months. I typically don't go further than that unless there's a reason, like I really want to see less disease burden in the liver, for example, then I might go out to a full 6 months. But typically we'll stop after 6 cycles because I don't want the patient to develop permanent neuropathy in the fingertips and have other toxicities. And then we'll maintain them on the HP, during which time their hair will be growing back and they'll be feeling a lot better.
Got it. So I think we probably really only have time for one more question. So this person is asking, is the leaky blood-brain barrier you refer to a consequence of treatments that we go through? Isn't that a bad sign despite making the brain more open to these drugs?
So the leaky blood-brain barrier may be in part due to radiation and surgery, because there have been studies that suggest drugs can get into that blood-brain barrier more easily after radiation and surgery. But if you think about it, the tumor cells themselves are enormous. They're larger than any of these molecules. And if they can get through the blood-brain barrier, that blood-brain barrier is already probably leaky. Something is going on there allowing those cells through. So I think our simplistic visualization of the blood-brain barrier is being challenged right now. I think we're still learning about it. I'm very pleased actually to see that these bigger molecules can get through and impact outcomes so well. It gives a lot more hope for our patients contending with brain mets and leptomeningeal disease. There's no evidence that having a leaky blood-brain barrier is harmful to a patient. And that was the other aspect of that question.
Yeah, yeah. Well, I can't believe this time has flown by, but first of all, I want to thank everybody on this session. And Dr. Hurvitz, you could probably scroll through and just see how engaged they are and how much they appreciate you taking their time. And it is exciting to see how many drugs there are and how many choices, and also the survival data. It's just phenomenal. I mean, it really does show what these breakthroughs do and then how they just continue to add to it. So Dr. Hurvitz, thank you so much for taking time to be with Living Beyond Breast Cancer, for helping this community that just always has such thoughtful, insightful questions. And I'm sure every day in your practice, you're challenged with a question.